Jim Wood is a GP partner in Tiverton, and he works with Ed and myself. And Jim, as I slightly alluded to before, has got a special interest in almost every element of medicine.
I'm not sure about
that. But particularly surgery, dermatology, and kind of emergency medicine. So I'll just hand you over to Jim, and he can tell you a little bit about that and what he does.
Okay, thanks, John. Hello, everybody. If anybody's got any questions at all, please just ask. John asked me to, he wrote to me before and said for me to tell you a little bit about my career. I'm currently a partner at Clare House Surgery, which is part of Amicus Health. And I do 4 sessions a week as a GP partner, and then I do 4 sessions a week as in various roles as a community surgeon. Really, I think would be the most accurate sort of summing up of it. Within that, I do carpal tunnel surgery, vasectomies, and then I do skin surgery, doing basal cell carcinomas, and then more benign surgery. Until the pandemic, I was also going down to Hevertree once a month and doing skin surgery down there in the dermatology department. Really, that was kind of worked both ways in a kind of training and supervision type side of things, but also from their point of view and having some extra surgical capacity. I also have had a career sort of doing emergency medicine, and until the pandemic, I'd been a middle grade in the emergency department on their weekend rota for 10 years or so. I kind of came into general practice from a background of having, I finished medical school, wasn't sure what I wanted to do, thought I either wanted to do anaesthetics and critical care or surgery. Then during my equivalent of foundation year, decided to do surgery. And then during my basic surgical training, realised a few things. Firstly, I quite liked continuity with patients, and I felt I was missing that a bit with surgery. And I really quite like making medical diagnoses, which I was also missing with surgery. And if I'm really entirely honest, the clinics, the surgical outpatient clinics, were getting a bit dull for me. And considering I was only an SHO, I thought this probably didn't bode that well. I loved the actual operating, but the real part of the job I loved was the critical care aspect. And I was struggling to marry all of this together. And then a colleague of mine in the emergency department said to me, "Why don't you become a GP?" And to start with, I was slightly shocked because this really hadn't occurred to me as a possibility before. And then he pointed out to me that he was a GP and he did emergency medicine. And he said that he was pretty sure there was a way for me to carry on doing surgical stuff as a GP. So I spent some time with him going to his surgery in Axminster. And I was amazed by how much GPs did. I really, as a hospital doctor, had no idea the complexity and the variety that we do as GPs. So I then decided to speak to various people about how could I carry on doing emergency medicine. I spoke to Adrian Harris, who is now the medical director, but then wasn't. He was a consultant. And he said to me that he thought I ought to get my membership for the Royal College of Emergency Medicine, which I duly did. I don't think you need to do that, though. And continue doing middle grade shifts. And so I carried on doing middle grade shifts. And as I did my GP training, I started doing those at the weekend. In terms of my surgical training, I was not quite sure how to go about this. The specialty of community surgery, as it's kind of umbrellaed, is very much, I think, still really in its infancy. People do a bit of this or a bit of that, and they tend to get GPSI accreditation in one thing or another. So, for example, vasectomy or carpal tunnel or BCC surgery, or now dermatology surgery, because the accreditation for that has changed slightly. but all of it is slightly under the umbrella of an organisation called the Association of Surgeons in Primary Care, or ASPC, if you decide to Google it. And that kind of fulfills a bit of a role, sort of pushing forward community surgery. Miles Taylor, I did a gynecology job, and there's a chap called Miles Taylor who said to me, the best place for you to go to do surgery is Tiverton. And there's a chap here called Mike Seymour who was doing a lot of surgery for the RD&E. And so I deliberately came to Tiverton to do my ST3 here. And I then decided, I then looked very much at whether I could work for the RD&E doing surgery. And although that was a possibility, it was appallingly badly paid, really, compared to GP pay. And it was kind of more in line with kind of sort of relatively junior SHO pay. And I think Mike had got a very historical contract. And added to which the CCG really weren't very keen to be promoting new services through secondary care. What they really wanted to do was start services going through primary care. So what I did was then did an ST4 doing community surgery. And within that, I started developing services to be run out of Clare House Surgery. And I started with vasectomy to start with, and then bolted on BCCs, and then bolted on carpal tunnels. And we now, as a service, provide carpal tunnels out of Tiverton and Sidmouth with my friend and colleague Andy Rosewarne. And obviously John does carpal tunnels out of Tiverton. And we do BCC surgery out of Tiverton. We provide a dermatology clinical surgery service with Helen Crichton. We also do vasectomies out of Dawlish. So I think we're quite a big as hospital provider of surgical and dermatology services now, possibly the biggest in Devon, I wonder. I wouldn't be at all surprised. So that's kind of where I've got to now. The only other thing I do extra now is I seem to do a lot of vaccinating at the moment, as well as the other things. So does that answer your first question, John?
Absolutely.
Excellent. You're on mute.
Absolute amateur hour. I mean, the number of hours I spent on Zoom and still forget to unmute myself.
I think in all our meetings, that's the first time I've seen you do that.
Yeah. Yeah, I think that definitely answers the question. And a bit of the second question, which I had, was kind of so from when you were an ST3, how did you kind of start to get into these things? So what opportunities did you have? How much was that kind of driven by you going on courses and all that kind of stuff? And how much of it was, stuff just fell into your lap and was offered to you?
So I think it's a really good point. I think A&E, as I just alluded to, I think pretty much if you show an interest in A&E or emergency medicine, and you do offer yourself regular locums, and also there's now a GP twilight doctor several days of the week. So once you're qualified as a GP, if you do that, I think it's very easy to integrate yourself into most departments. I know that Taunton are periodically looking for people. I know that Exeter are too. I think, do you need to get exams? I don't think I needed to. I mean, other people that I've worked with over the years, didn't. I think it helped me getting the exams. I think it was quite enjoyable in a way. And certainly when I was doing night shifts and I'd be the only middle grade, it was quite nice to know that I had my membership. But I really don't think you need to. I think those things kind of change over time, though. In terms of the other stuff, I think really there's a lot about enthusiasm. I think that's the thing I'd say is the most important thing to have. If you're enthusiastic, people are keen to open doors for you. And there were when I started on my sort of wanting to do surgical stuff, there really wasn't any kind of set way to go about that. There weren't really any kind of courses as such. You kind of had to integrate yourself with departments in the hospital. And the biggest challenge was really aligning the hospitals' intentions for services with the CCG's intentions. And so vasectomy was quite easy because there was a bit of a national push to get vasectomies out of hospital. So that one involved me going to quite a lot of meetings with the CCG and with urologists to kind of bring that about. And then really, I mean, Malcolm Cromwell's the urologist that helps us with our service. He's been hugely supportive of it over the last, 11 years. And I think that's a big part of it, is sort of talking to people and making sure you've got people on your side. Carpal tunnel, similarly, that allied itself in that the CCG was realising that actually carpal tunnels were massively expensive in secondary care and could be done much cheaper in primary care. And we'd already set up a service by that stage to do them. Skin stuff, again, dermatologists are a very friendly bunch and very supportive. And fortunately, there's a sort of quite national push to kind of get as much dermatology done in the community and closer to the patient, really, as possible. Courses are very important, but I'd say that actually the more important thing is having somebody on your side, and also the factors aligning in terms of the CCG and secondary care being happy for them to happen as well.
Cool. Next, what do you like about being a GP?
I love being a GP. I honestly have never had a day of being bored, which I can't think of any other job I've had that I've felt the same about. I think GP's changed a lot. It used to be that GP could feel a bit lonely at times, but the team working now is much different. Certainly, amongst GPs, certainly where we are, I think we're very lucky and there's a very strong team ethos. But it makes a big difference knowing that your mates are in the same building as you and you're popping in and out to ask questions and talk to them about cases and stuff. The flexibility of being a GP is massive. Yeah, there's no other specialty that you can dip your toe in the water. There's no other. If I'd carried on in surgery, there's no way I could say, oh, and I also do a bit of emergency medicine, I also do a bit of dermatology, and I also do a bit of general practice. And likewise, if I carried on and done emergency medicine, there's no way I could be doing any surgery or dermatology or general practice. It's the only specialty that allows you to pick up other specialties and make them into a kind of special interest for yourself. The patient follow-up for me is massively important. I love the fact that I see people. I've just seen a patient actually this afternoon, and I can remember her when she was 11 and she's just had a baby. I've just met her baby. It's awesome. I think so. Knowing the patients and following them through is really important. The other thing is there's something in general practice, although you're at the whim of a larger organisation in terms of NHS England, who may suddenly announce that you should be offering everybody face-to-face appointments if they so wish. You're actually not, because you can turn around and go, that's not in our contract. And actually, we're still going to carry on doing what's sensible and best for our patients. I think that, it's for me, it's a perfect career, allows flexibility and variability and a degree of independence.
Cool. How do you cope with things? What do you do to cope when things get hard in GP?
Yeah, this is a good one. I thought about this. I talk to my wife quite a lot, but I'm not sure if that's the answer I meant to give. I think talking to people close to you is really important. I think talking to colleagues as well. If you've got a difficult case, then talking to the MDU or other sort of people, consultant colleagues, etc., is very useful. I think quite often there's things. So when I felt really pressured in general practice, generally there's a way for me to depressurize that situation. And it's either by looking at the situation and realizing that it doesn't all need to be done right now, or it's realizing that actually the pressure is that I've decided that today I'm definitely going to get home in time for the kids' bedtime or something like that. And sometimes you don't realize that actually the pressure that you're under is actually a pressure of your own making, in that you've set yourself a standard that actually isn't that fixed. And so quite often I realise that I'm in control of shifting that standard. So if I've potentially said to a patient, I will get back to you today, actually, I quite often realise I don't need to get back to that patient today. I've got time to decompress that situation and get back to them tomorrow. I also think just always knowing that in your pocket you've got the phone the friend option, I think is invaluable.
Cool. Kind of finally, so you're talking to a bunch of ST3s who are just about, well, there are various stages, but imminently are going to go out into the wide world of general practice. Do you have any top tips that you would give to these guys about starting out in general practice?
Yeah. The first thing I think, so the thing that I nearly completely messed up completely, I think, with my own ST3 was the penny dropped for me very late that consultation skills were incredibly important. I think as doctors, we do a lot of consulting and we think we know a lot about consulting. And then I only started really reading around the subject of consultations after I'd been doing ST3 for probably about 9 months, and realised that there was a whole massive area of knowledge that I'd kind of assumed that I'd got by just doing the job. And although my trainer was telling me that I was consulting very well, I realised that I hadn't actually tried a lot of different techniques or different consultation models, or tried different tactics in consulting. And I still go on I still read a lot about the consultation now, and still, like last year I went on a consultation skills course. And I think that I wish that I'd spent, when you've got longer appointments, when you're an ST3, I think I'd use those more to try different things, try a little bit of confrontation, try a little bit of silence, try a little bit of this, that, or the other. The other thing is that I realised quite quickly that dictating as you go along makes a massive difference to your time and your work pressure. And I would really encourage anybody to be comfortable dictating in front of patients, and to dictate or finish up the housekeeping for each consultation at the time of that consultation. It saves you so much time and pressure. Dictating in front of the patient, I know we're in this COVID world where we're on the phone a lot, but when you're face to face with the patient, if you dictate in front of them, the patient satisfaction is, the increase in it is just palpable. They love it. And added to which, they know what you've said, they know that you've taken on board what they've said. Quite often it reduces your consultation time, because if you tell a patient you're about to refer them, they often use this as a prompt to try and tell you the whole story all over again. Whereas if they've just heard you dictate the whole story, they no longer have that need to re-emphasize things that they've said. I think taking breaks is important, whether that be holidays or breaks within clinics or breaks within the day. Try and learn skills as you go along. Learning, for example, a hall pipe maneuver is very easy. It's amazing how many doctors don't know how to do it. Oh, John, have I lost you? No. And the other thing I'd say is, I think it's really tempting when you get to the end of your training to launch yourself into an 8-session job, or 10-session even, some mad people try and do. I would really, really try not to do more than 6 sessions. You can always do out of hours or other things, but if you decide you want to develop an interest and you're already doing 8 sessions, it's almost impossible to then develop that interest and bring that into your work plan without, at some stage, going up to 10 sessions or even more. I can remember at one particularly stupid stage in my career, I was 11 sessions in order to try and bring the surgical service on. And in retrospect, that was a very bad idea. I remember giving one of my colleagues the advice not to do 8 sessions, and at the time he was quite annoyed with me for saying this. But I think I was right, wasn't I, Job Boy?
Yeah, it's true. I would, yeah. So when I was starting out, Jim said to me not to do too many sessions because then you left some space in your week to explore other interests, and that was really good because being available, loads and loads of opportunities come to you as a GP, and if you're working 8 sessions in practice, you can't do that. So yeah, so I would start off on the conservative side of the number of sessions you want to do, and then it's a lot easier to build up sessions than it is to get rid of them once you've got them.
Yeah, absolutely. I think it's paralysing if you're doing more than 6. Really, and you're right, John. There are so many opportunities that come your way. You know, they just naturally fall your way, and it's incredibly frustrating if you can't take up on them.
Great. So there's a couple of questions that have come through in the chat. The first one from Alice is, how did you learn to do a vasectomy?
So while I was a surgical trainee, I'd done some vasectomies, and I suspect incredibly badly. When I was then started at Clare House, I was kind of I'm not sure I was allowed to do this, but I kind of did it anyway. My self-study session in the week, what I actually did was went to theatre in Tiverton Hospital with Mike Seymour and kind of learnt how to do vasectomies, his way of doing vasectomies. And then I subsequently went on a course in Essex to do no scalpel vasectomy. There are now, though, various vasectomists that do run courses and will teach vasectomy. And you can, if you look on the ASPC website, then there's information there on how to use who teaches those.
Done it again. How do you balance your ratio of normal GP work with your surgery, dermatology, and A&E shifts? So, what does a normal week look like for Dr. Jim Wood?
So, normal pre-pandemic week would be Monday GP all day, Tuesday operating all day, Wednesday GP all day, Thursday morning doing a clinic, a surgical clinic, and then Thursday afternoon doing a theatre list. And then Fridays I'd changed it. So I used to be on a weekend rota of doing what worked out as 5 sessions every 6 weeks. I know it's 6 sessions every 6 weeks, but then I changed it to 2 sessions a month. So one Friday a month I'd be in A&E. Mind you, that was a 10-hour shift, so it's 2.5 sessions.
And did you find that worked okay?
Yeah, that was good. I did do a time when I was doing 5 days a week general practice, and then I'd do a whole weekend of A&E, and then go into the next 5 days of general practice. That's not hugely sustainable. I wouldn't do that again. Mind you, maybe I did it and found it okay because I was younger. So maybe you guys would find that okay. I don't know.
Don't do it. I wouldn't. Just don't even entertain the idea. That's absolutely nuts. Does anybody else have any questions for Jim about general practice or GPSI work? It's so quiet.
I just want to say, Jim, I think that was really helpful. It's really interesting to hear all about the different things you do, but also to hear you being really enthused about general practice as well, not just how it fits around the other things that you do.
Yeah, interesting. There was a stage where my partners wanted me to drop my general practice bit. They wanted me to reduce it back to do more surgery, but it would mean that I wouldn't have a list. So I gracefully declined, because having a list actually for me is very important.
Can I ask a question? it's about dermatology. So I'm just kind of interested in what you are and like where the boundary is with what you're allowed to do in primary care.
So it's a good question, and this is always evolving. So there's a new accreditation process called the GPER. So it used to be GPSI, and it's now GP with extended roles. And it's an accreditation process that's been put together by the RCGP and the dermatology part of the Royal College of Physicians. And essentially, it's now kind of split. You can either become a GPER in lesions, which means that you do surgery and lesion recognition, or you can become a GPER in clinical dermatology, which means that you're doing more kind of clinic-based dermatology, but that's more rashes than lesions. They've kind of split it along that kind of pathway. In terms of what you do in primary care, it slightly depends on where your accreditation lies within that surgical part. So there's this concept called low-risk BCC, which is a BCC below the clavicle. So we're very much kind of doing that here. However, you can kind of do sort of more than that. So for example, the MDT are quite happy for us to do SCCs, but because we're not a 2-week wait service, we shouldn't do it. We shouldn't be sort of touting for SCCs as such. But if one comes up, if one comes into us, then we'll take it off because it's pretty much the same skills. And otherwise, you've got to send the patient back through the system. But so, for example, we don't do melanomas though. But having said that, if I see one, I'll take it off because that's what I do when I'm inhibitory.
And how about non-cancer stuff? Do you take?
Yeah, there's not a huge amount of non-cancer stuff that comes through, and the reason for that is that it's under what's called the LVP. So it's considered anything non-cancerous is considered a low-value procedure, which is the code word for the NHS doesn't think it's worthwhile. So we'll do biopsies, and then there'll be some pre-cancerous stuff like Bowens that we can do, or actinic keratoses that look like they may be causing problems. But cysts, for example, which is the other sort of thing that comes through, the GP has to kind of say this cyst has been recurrently infected and causing a problem, and it has to meet this various criteria before it can come to us. But we do them.
There's another question in the chat just about work-life balance, and kind of, are you happy with where you are? Any tips for the guys? And how do you make sure that things away from work are kind of okay, given that you've kind of painted a picture of a fairly busy GP, I would say?
Yeah, so I have a 3-day weekend, the vast majority of weekends, which I think is pretty good, really. My days of work, I kind of get in for about 8, and providing I don't end up chatting with people, I can leave kind of between 6 and 6:30. But not pointing any fingers, John. So I think that's not a bad day, really. And it is 4 days a week. But to be honest, the variety makes up for it quite a lot. I think having variety in any job means that actually you're feeling quite fresh most of the time. Mind you, I think I'm looking a bit older than my years. You know, I am only 32 now, and yeah.
I'm not even going to.
No, don't, mate,
don't. Lovely. Anybody? Any other questions? I think not. So thank you, Jim. It's really helpful to hear from somebody who has been doing general practice a while and still finds it really interesting, has developed their career to be what they want it to be, and has managed to stay doing GP clinical work, but also has found lots of other areas of interest to kind of make for a kind of sustainable long-term career. So thank you very much.
Right. Thanks, mate. If any, John, I'm happy for people to have my email address if they want to ask me any questions at any stage, and that can be now or future in their career.